Hello, in this topic I will talk about airway. So what is your airway? The airway, the natural airway, is the path taken by the atmospheric air to reach the alveoli. Okay, so that is your natural airway. So this comprises of the three pharynx, the larynx, the trachea, the right and left bronchus, and ultimately alveoli. This is your natural airway. If you put any device into this natural airway, that's called artificial airway. Okay, so as I told, natural airway is path taken by atmospheric air to reach the alveoli. Path taken by atmospheric air to reach alveoli. Okay, so this is your natural airway. So as I told you, the all pharynx, then larynx, then your glottic opening through after larynx, then your trachea, then your right and left bronchus, then all the bronchioles, ultimately alveoli. Okay, so if I put any device into this, that would be called artificial airway. And in this topic, we'll talk about the artificial airways. Okay, so artificial airway is device inserted in natural airway. Okay, now why do we need to insert the device? There are two reasons. One, for some reason, if the patency of the airway is lost, trauma, unconsciousness, if the patency of the airway is lost, we need to maintain this natural airway for the free passage of the gas to the alveoli. So we put the device. And other reason is that we need to maintain the patency and also for artificial ventilation, right? Then those devices which is just used for maintaining the patency, we call them basic airway devices, and the devices which can also be used for ventilation, we call them artificial airway, advanced airway devices. So your airway maneuvers and devices can be divided into basic and advanced. Okay, so basic airway maneuvers and devices are just used to maintain patency of the airway. They maintain patency of airway. Okay, and advanced airway device, they not only maintain the patency, they are also used for ventilation. So they maintain patency and used for ventilation. So in basic airway devices, we have your oropharyngeal airway, nasopharyngeal airway. These are the adjuncts and some basic airway maneuvers which we do. And in advanced airway devices, we'll discuss about the endotracheal tube, supraglottic airway devices, right? So we will divide the airway section in two parts. First, I will talk about the basic and then I will talk about advanced. So let us start with basic airway devices or basic airway maneuvers. So basic airway maneuvers, first we will start with. So whenever you are in emergency, right? Whenever you are in emergency and you receive a patient may be a trauma patient may be unconscious patient due to some reason for the coma, patient has gone into some toxin ingested, anything, and the airway is compromised, airway patency is not maintained. We need to do some immediate maneuver to open the airway because it is an emergency situation. If the atmospheric air will not reach the alveoli, oxygen will not reach the alveoli, and hypoxic arrest will happen. To prevent that, we need to open the airway. So two important basic airway maneuver is what we need to know about to open the airway. The first maneuver which I would discuss with you is head tilt, chin lift. Head tilt, chin lift. Okay, so this head tilt, chin lift maneuver I will discuss, and the second maneuver would be jaw thrust. Now both these maneuvers are used to open the airway, maintain the patency of airway. If you see this image of the airway, you can see that this tongue, this is the tongue. Okay, this tongue which forms the boundary, the anterior boundary of the upper airway. Now this tongue and this epiglottis, they are made up of soft tissue, and in case the patient becomes unconscious or any trauma of the upper airway, they fall on the posterior wall of the airway and they obstruct the airway. So these basic airway maneuver, they are basically maneuvers which lift the tongue from the posterior wall of the airway and maintain the patency of the airway. So this is the first image. This is the image of head tilt, chin lift. As you can see in this image, with one hand, head is tilted backward of the victim, and with the other hand, the chin is lifted upward, right? So this maneuver, what does it do? Normally, the tongue is falling in case of coma and in a case of obstructed air. Tongue is the most common cause of causing obstruction. When this head tilt and chin lift maneuver is performed, this tongue is lifted and the patency of the airway is again restored, right? So this is how it restores the patency of the airway, by lifting the tongue. So head tilt, chin lift. This maneuver, this simple maneuver lifts the tongue from posterior airway, lifts the tongue from posterior airway and maintain the patency of the airway, and maintains patency of the airway. So this is how the patency of the airway is maintained. But if you are seeing this maneuver, there is movement of head and neck. Now this head is tilted backward, head tilt. So there is movement of head and neck. So when there is movement of head and neck, movement of head and neck joint, right? There is then in case of cervical injury patient, trauma patient, this movement can be injurious. This in trauma victim, we don't want head and neck to move. So when trauma patient comes to us with obstruction, this is not a maneuver, first maneuver which we practice, because this causes movement of head and neck. In that, what we want to practice is your jaw thrust. So the second maneuver which I will talk about is jaw thrust. Now this maneuver, jaw thrust, in this maneuver also the tongue is lifted from falling on the posterior wall of the airway. In this maneuver, with both our hand, we stabilize the head and neck joint of the patient, and with both our thumb, we protrude the mandible forward. So both our hand is doing the same work. In head tilt, chin lift, one hand was tilting the head backward and other hand was lifting the chin upward. But in jaw thrust, we are holding the victims, we are cupping the head of the victim in both our hand, and with our thumb, we are protruding the mandible forward. So jaw thrust is simple maneuver in which head and neck is stabilized. Head and neck is stabilized, and with thumb, mandible is protruded forward. Mandible is protruded forward. Okay. So this maneuver also does the same thing, lifts the tongue. So this is your jaw thrust maneuver. This maneuver is the maneuver of choice in trauma victim. This is the first maneuver which you practice in trauma victim. So you can see this is the jaw thrust. Jaw thrust. So image based question can be asked. They can give the image and they can ask you to describe the maneuver which is being performed. So for jaw thrust, as I told you, both the hand will do the same thing. And for head tilt and chin lift, one hand will let's say tilt the head backward and other hand will lift the chin forward. Okay. So let us just compare both the maneuver. Head tilt, chin lift. Head is tilted backward. Head tilted backward and chin lifted upward. Chin lifted upward. This is how we perform the maneuver. Jaw thrust. Head and neck stabilized. Head and neck stabilized. And mandible protruded. Mandible protruded forward, right? So both the maneuver is doing the same thing by two ways. They both are lifting the tongue away from posterior wall of the airway, from falling on the posterior wall of airway. So both the maneuver are doing the same work. Head tilt chin lift, this is a better maneuver, right? This is a better maneuver compared to jaw thrust. But in head tilt chin lift, movement of head and neck joint, So neck joint. So not first maneuver in trauma. So not first maneuver in trauma victim. Okay. Whereas your jaw thrust, this is the first maneuver which we practice in trauma victim. So this is the first maneuver in trauma victim. Okay. So jaw thrust is the first maneuver in trauma victim and head tilt chin lift is the first maneuver in non-trauma victim. So remember, for non-trauma victim, head tilt chin lift, and for the trauma victim, jaw thrust is what we practice. So clinical questions are asked, describing the clinical scenario and asking which maneuver will be performed. If it is non-trauma, head tilt chin lift because it is a better maneuver. And if it's a trauma victim, we go for jaw thrust, okay, because it keeps the head and neck joint stabilized. Then image-based question, giving the image of the maneuver and you are asked to recognize the maneuver. So you can easily recognize it, okay. So these are the basic airway maneuvers. Now, once we have opened the airway, we cannot keep on holding the victim. So we need some airway adjunct to help us. So now comes the role of your simple basic airway adjuncts or oropharyngeal and nasopharyngeal airway. So let us talk about basic airway adjunct. In this, two devices is what we need to discuss. Oropharyngeal airway and your nasopharyngeal airway. Okay. So again, lot of clinical questions can be asked. Oropharyngeal airway. So I'll show you, this is the oropharyngeal airway. Okay, I'll describe the parts of it and the advantage and disadvantage. And then we have nasopharyngeal airway. This is the nasopharyngeal airway. As the name suggests, oropharyngeal airway is inserted from oral cavity, remains in pharynx. So this is inserted from oral cavity and remains in oropharynx. Okay. And nasopharyngeal airway, inserted from nasal cavity and remains in oropharynx. So both the device remains in the pharynx only. Okay, they remain in the pharynx only. Okay, one is inserted from oral cavity, other is inserted from nasal cavity. So let us first discuss the OPA, that is oropharyngeal airway. So we'll discuss first OPA. Okay, now oropharyngeal airway, you can see there are various types. The image is given of Goodell airway, which is the commonest one which we are using, a type of oropharyngeal airway. In my hand is also the Goodell airway. So you can see the image and you can see it. I am holding a oropharyngeal airway in my hand as well. So let me just describe the parts. This is the flange. This is flange. Now what is the use of flange? The flange remains outside the oral cavity and prevents the forward migration of the airway. So it limits the depth of insertion. Then it is color coded according to the size, and this is the bite block. So this is bite block. Now bite block, because you are inserting it from oral cavity, teeth comes in between. It can bite and obstruct the airway. Then this is the rigid kink resistant body of the oropharyngeal airway, which pushes the epiglottis away and keeps the epiglottis away, and in its curvature it will hold the tongue, it will lift the tongue. Then the tapered end, and there is, let's say this is a tapered end which will cause minimal trauma to the mucosa, and there is opening. There is a oval or a circular opening. In the Goodell's airway, we have a oval opening, which we can use for suctioning, etc., by insertion of a suction catheter. So this is the part of oropharyngeal airway. Now this airway is made up of rigid plastic, okay, rigid plastic. Now let us talk how do we insert it and how does it do the work. So to insert it, it comes in assorted size. So it comes in assorted size. To insert it, first you need to measure the correct length which would be inserted in that particular person. See, even in adults, we would need two different sizes of the oropharyngeal airway. It depends upon the anatomy of the person. So first we need to choose the correct size. See, color coding is according to the sizes. So how do we choose the correct size? To choose the correct size, you hold the flange to the angle of mouth and bring the tip. This flange is held at angle of mouth, right? And the tip is brought to the angle of mandible. And the tip is to the angle of mandible. Tip should correspond to the angle of mandible. Always we have 3-4 sizes with us. We measure the correct size. So this would be the correct length of the oropharyngeal airway which would be inserted in that person. If you will not choose the correct length, then if it is of smaller size, then it will not do the job of lifting the tongue. The tongue will drop from the oropharyngeal airway. It has to lift the tongue in its curvature. And if it is of longer size, then it will itself cause obstruction by irritating the posterior pharyngeal wall. So we need to choose the correct size. So first what we do, we choose the correct size. Choose the correct size. So how do we choose the correct size? We choose the correct size by simply measuring from angle of mouth to angle of mandible. So measure the length, right, from angle of mouth, angle of mouth to angle of mandible, So this is how we choose the correct size. So once the correct size is chosen, how do we insert it? The most common method of insertion is holding it in upside down position, right? So this is the way it will be in the oral cavity, okay? So I make it upside down, right? Holding it in upside down position. And then we open the oral cavity, insert half inside and then rotate it to 180 degree and then push it. So when I rotate it to 180 degree, it lifts the tongue in its curvature and then I push it. This is the easiest way. The other way is we can insert it in the same way. It is in the oral cavity. We lift the tongue with a magal forceps, insert it and put the tongue on its curvature, okay? Or we can also insert it by in a half rotated form, not in upside down like this, and then we moved it after inserting half to the 90 degree. It will also do the job. But the commonest is that we hold it in upside down position, half inserted in the oral cavity and then turn it to 180 degree and then push it, okay? So this is the upside down method. Upside down method of insertion. Okay? So as I described, this is how we most commonly insert it. So I told you it is made up of rigid plastic, isn't it? It is made up of rigid plastic. So when we are putting it in the oral cavity, if the patient is conscious, this can stimulate reflexes, the oropharyngeal reflexes, the gag reflex, etc., and can cause laryngospasm. And even the conscious patient will not tolerate it, will try to push it away. If you will force it inside, it will cause the reflexes to get stimulated, laryngospasm, etc. can happen. So this is a very good device to lift the tongue in an obstructed airway, but not for conscious patient. So should not be used for conscious patient. So OPA, number one point which we have discussed, it lifts the tongue in its curvature, right? Number two, right size should be chosen. Right size should be chosen for the correct insertion right? And how do we measure the right size? We measure by angle of mouth to angle of mandible. Then, should not be used in conscious patient. Should not be used in conscious patient. Conscious patient. So if you will use it in conscious patient, it will stimulate lot of reflexes. So this is device of choice. Device of choice to open the airway in unconscious patient. Unconscious patient. So for unconscious patient, definitely this is the device of choice. But for conscious patient, we should not use it. So what device we should use for conscious patient? We should use nasopharyngeal airway. Nasopharyngeal airway. So let us talk about nasopharyngeal airway. Okay. So this is our nasopharyngeal airway. As you can see it in the image also, in my hand also. It also has a flange, a body, and it also has a tip. And if you can see the tip is beveled like the tip of endotracheal tube. So it has a beveled tip. So it has a beveled tip. It has body and channel like oropharyngeal airway, and this is the flange. So you don't need the blight block because it is not inserted from oral cavity. So it is inserted from nasal cavity. Simply, how do we insert it? You can see this also comes in assorted sizes, right? So first thing which we do, we choose the correct size. How do we choose the correct size? By measuring from angle of nose or tip of the nose, ala of the nose or the tip of the nose to ear lobule. So this also comes in assorted size. Assorted size. So how do we choose it? Choose the correct size. Choose correct size. How? By measuring from angle of, nasal ala or tip of the nose, from tip of nose to your ear lobule. So this would be the correct size to be inserted in a person. Okay. So once I choose the correct size, what do? I lubricate the tip and insert through the nasal cavity, the more patent nasal cavity, with by a screwing movement, and this beveled end, right, should face the nasal septum. So by a screwing movement we insert it. Okay. What does it do? Does it lift the tongue? No, it does not lift the tongue. It creates a channel for the air to pass. It creates a rigid channel for the air to pass. So nasopharyngeal airway, this creates a channel for air to pass. It does not lift the tongue. Okay. So this is how it acts. Okay. So what are the points of nasopharyngeal airway which we discussed? Nasopharyngeal airway inserted from nasal cavity or nares rather, and it creates a channel for air to pass. Does not lift the tongue like oropharyngeal airway. Correct size is chosen prior to insertion. Okay. So first you have to choose the correct size. Okay. Then this is device of choice in unconscious patient. So this is device of choice in unconscious patient. So for unconscious patient, this is the device of choice. Unconscious patient. So if it is a good device for it is a device of choice for conscious patient. Okay. So chosen prior to insertion we have written, and this is a device of choice in conscious patient. For unconscious patient, what was the device? The device was oropharyngeal airway. This is device of choice for conscious patient. So if it is a very good device for conscious patient, why should not we put it for unconscious patient? The reason being that nasal cavity is a very vascular cavity and we don't want to touch it until and unless it is required. So in unconscious patient, it is good enough that we use the oropharyngeal airway, and only in the conscious patient we use nasopharyngeal airway. So it is reserved for conscious patient. So it stimulates less reflexes. It stimulates minimal reflexes, minimal airway reflexes. Okay, so minimal airway reflexes, well tolerated. It is well tolerated by conscious patient. So this is oropharyngeal and nasopharyngeal airway. What are the questions which can be asked? Image-based question to recognize the device, how to choose the correct size, and then a clinical scenario in which they will describe the patient, conscious, unconscious, and they will ask you which airway device we need to insert. So we discussed 4 things. We discussed 2 airway maneuver, that is your head tilt, chin lift and jaw thrust, and 2 airway adjunct, that is oropharyngeal and nasopharyngeal airway. Both of these are, total all the 4 things which we discussed are used for opening an obstructed airway, right? It is not used for ventilation. We just open an obstructed airway with these maneuver and these devices. So they come under basic airway maneuver and basic airway adjuncts. Okay. So this is all about the basic airway maneuver and basic airway adjuncts. Now we will discuss advanced airway devices. Okay.